the homework. So, Ranju, do you know what is the treatment for erythroblastosis fetalis? Ranju, are you there? Can you tell me what is the treatment for erythroblastosis fetalis? Can you tell me the treatment for erythroblastosis fetalis?
Sorry, ma'am.
Yes or no? No.
No, ma'am. I know only the prevention.
Prevention, I had told you in the class, but I had not told you
Yes.
about the treatment aspect. So, Saksham, can you tell me what is the Saksham, can you tell me the treatment for erythroblastosis fetalis? Yes or no, Saksham? No. Didn't study. Hmm? Saksham, I didn't hear you properly. What did you
Yes,
say?
yes, ma'am.
Can you tell me? Can you tell me the treatment aspect for erythroblastosis fetalis?
Ma'am, with
Yes
the
or no?
ma'am, blood transfusion.
Okay, somehow I think some net problem. Can't hear you properly. Anyway, please, all of you, please read about the treatment aspect also. Okay, I'm not going to talk about the treatment aspect today. I'm going to start with the blood transfusion. And so objectives of today's class will be to provide overview of transfusion therapy, to describe about reaction can we come across. All right. Am I audible? Am I audible or not?
Yes, ma'am.
You are, ma'am.
Okay. Okay, so today we're going to talk about all about blood transfusion. Okay, so overview of blood transfusion. What is blood transfusion and some of the important facts about blood transfusion. Okay, so blood transfusion, it is a process of transferring blood-based products from one person into the circulatory system of another person, right? And every 2 seconds, someone needs blood. And even with all of today's modern technology, there is no substitute for blood. That means someone has to give blood in order for someone to receive blood. Okay, so even though there is a lot of technology going on, new technology coming up, but still we need someone's blood to give to someone. There is no substitute for blood. Now a person has 5 to 6 liters of blood in their body, right? Now a person, a normal healthy person, can donate blood every 90 days, that is every 3 months. Within this 3 months, body can recover the blood very quickly. Blood plasma volume, it can recover within 24 to 48 hours, and the red blood cells can recover within 3 weeks, and platelets and white blood cells can recover within minutes. So every person has to donate, or every person can donate blood every 90 days, because within 90 days all of the blood constituent they recover. Now, why we have to transfer blood? What are the indications for transfusion of blood? So whenever we have blood loss due to accidents or due to some kind of surgical operations, right? Likewise, due to blood disorders, in case of hemophilia, purpura, anemia, leukemia, in all those cases also there is indication for blood transfusion. Then in carbon monoxide poisoning also there can be indication for blood transfusion. And pre or post operatively in building up and making up the loss which took place during surgery also indicate for blood transfusion. And in different kind of shocks, I think shock, you know it properly, so we have different kind of shocks, and in shocks also there is need for blood transfusion. So these are some of the indication why we have to do blood transfusion, right? During blood loss, during blood disorders, any kind of poisoning, or during shock, we have to transfuse blood. Now, like we are transfusing blood, right? So it is mandatory for us to know which blood group is compatible with which blood group, right? So in order to understand that, I think this particular picture or this particular table will give you a clear indication of which blood group can receive blood from which blood group. So let us talk about this table. We have here blood group over here. That is, we have blood group AB, we have blood group A, we have blood group B and O. So we all know that in blood group AB, we have antigens present, right? Whenever we talk about blood group AB, so AB has antigen on their cell membrane, that is A and B antigen, right? So since there is present of both the antigen on the RBC membrane, there will be absence of antibodies in the plasma, right? So since there is no antibodies present in the plasma, this AB can receive blood from all the blood group like AB, A, B, and O, because there is no antibody present in the plasma of the people who is having the blood group AB. Whereas, whereas they can give blood only to AB. Why not to A? Why not to B? Because they have antigens present both A and B on the surface of the cell membrane, right? So if they give blood to A, there will be antibodies against the B antigen, and because of that, there will be again some kind of transfusion reaction, or there can be agglutination reaction coming up. Because of that, we cannot give AB blood to A group. I hope you are understanding, right? So let me say it again. We have blood group AB, right? And it has the antigen A and B on its cell membrane. And they do not have antibodies on their plasma, right? So because they don't have any antibodies in their plasma, they can receive blood from all the blood group like AB, A, B, and O. And they can only give blood to AB, but not to A and B. But we can think like we can give to A, but we can give to B. Why not we can give to A and B? Where the thing is, we cannot give blood AB to A group because blood A, the people who are having blood group A, they are having the antigen A only, and they have the antibodies B, anti-B on their plasma. Because of these antibodies in the plasma, it can react with the antigen of the AB group. So there will be some kind of agglutination reaction coming up. Because of that, we cannot give AB to A or B, right? Now, similarly, we have A blood group. It has the antigen A on its surface, and it has the antibodies anti-B on its plasma. Now, this A can give blood to A and AB both, right? But it can receive blood from only A and O. Reason being the same as we talked about AB, right? Now we have blood group B. It has B antigen on its surface and it has anti-A antibody on its plasma. That means it can give blood to B and AB, right? And it can receive blood from B and O. Now O blood group, you see, it does not have any antigen on its cell membrane, and it has both the antibody A and B on its plasma. So since they have both the antibodies present on the plasma, they can give blood to all the blood groups like AB, A, B, and O, right? And they can receive blood from only O. So you can see from this chart that AB can receive blood from all the blood group like AB, A, B, and O, whereas O, they can receive only blood from O, but they can give blood to all the blood groups like AB, A, B, and O. So see, because of that, O is called as the universal donor, whereas the AB, it is called as the universal recipient, right? So AB can receive blood from all the blood group and O can give blood to all the blood groups. So you see, it is because of the presence of these antigens and the antibodies. So whenever we talk about this transfusion, we have to think about the antigen and the antibody. So you see, AB blood group have no circulating agglutinins or no circulating antibodies, and therefore they can be given to any blood group people without developing transfusion reaction. That is why it is called as the universal recipient, right? So AB blood group, they do not have the circulating antibodies, and therefore they can give blood to any blood group without causing any transfusion reaction. Therefore they are called as the universal recipient. Whereas the O blood group, they contain no agglutinogen, or they do not contain any antigen on the surface of the RBC membrane, and therefore they can be given to anyone. So therefore they are called as the universal donor. So you have to remember which is the universal recipient and which is the universal donor. So anti-AB is the universal recipient because they can receive blood from any blood group because they do not have circulating antibodies. And O blood group, they do not have any antigen on their surface, therefore they can give blood to any blood group, therefore they are called as the universal donors. And another thing about the RS blood group is that RS positive can receive blood from only RS positive and the RS negative, whereas the RS negative can receive blood from only RS negative. Again, it is the cause for because of the antibodies, right? So RS positive people can receive blood from RS positive as well as RS negative, whereas RS negative, they have to receive blood from only RS negative people. Okay. Now this blood, from where the blood we get? So there are certain bank where the blood is being deposited, and this is called as the blood bank. So I think you are all aware of that. We have blood banks in most of the hospitals, and this blood bank, they collect, they test, they store blood, right? And there is something called as the autologous transfusion. Autologous transfusion means, like, suppose I have been planned for some kind of surgery next month. So what does the doctors do is that they will collect my own blood and they will store it in the blood bank. And when the surgery is being performed and there is the need for blood, then my own blood, which was stored earlier, right? That blood will be utilized after the surgery occurs. So that type of transfusion is called as autologous transfusion. And the other kind of transfusion is we get blood from other people, right? So this kind of blood will be stored in the blood bank. Now the question is, how will they be stored? So blood, they will be stored at the temperature of 4 degrees Celsius plus minus 2 degrees Celsius, right? And this stored blood has a shelf life of 3 weeks. Why we cannot store more than 3 weeks is because after a storage time of 24 to 72 hours, RBC have reduced capability to release oxygen to the tissues. So the capacity of the blood, the capacity of the RBC, it will be declined. Because of that, it does not have a very long life for the storage. So we can, at the most, we can store the blood for about 3 weeks, and at the temperature of 4 degrees Celsius plus minus 2 degrees Celsius, right? Now, why do we store blood? So this blood is being stored so that it will be utilized at the time of need, right? And this blood, it will be stored in combination, like this blood will be combined with the citrate and the dextrose in the following forms. Like there will be acid, citrate, dextrose solution, or there will be citrate, phosphate, dextrose, adenine solution. So our blood, which was been taken from the patient, it will be mixed with the acid, citrate, dextrose solution, or the citrate, phosphate, dextrose, adenine solution. So this will actually provide a medium where there will be reaction taking place and which will make the cells viable, right? And because of that, we have to store the blood in this solution, like dextrose and the citrate solution. This chemicals, it will provide a suitable medium for the reaction to occur. Thereby, it will help to store the blood for some time. Now, before we transfuse blood, there should be some kind of testing done. So, as I told you earlier, the chart which I showed you, right? It shows the same thing: ABO and RS blood grouping, or we can also say it as a blood typing. Okay. So, in ABO and RS blood grouping, we are actually finding out the blood group of the donor as well as the patient. So, it is also called as the blood typing, where we find the blood group of the patient as well as the donor. And this is one of the exercise we have to do. So uh, we mix our blood with the antisera which is present in the lab, and then we look for agglutination reaction to occur. So this particular test we will be studying in the next class, because this is a practical which we will be doing, and this practical will be taken separately tomorrow. Okay, so I'll not talk about how we do the blood typing, but blood typing, just you have to understand that we are doing blood typing to find out our blood group as well as the donor's blood group, right? As well as we will find out the which blood group via the ABU system as well as by the RH system. So those both the system will be able to rule out the help of blood typing. The second thing what we have to do is cross matching of blood sample. In cross matching, what we do is there is again two type of cross matching. One is major cross matching and one is minor cross matching. In major cross matching, what we do is we mix the patient's serum with the donor cells. So we are so you see we are mixing the patient's serum, which is the recipient serum, with the donor cells. So patient serum is in maximum amount and the donor cells in the little amount. So because of that, it is also called as the major cross matching. In minor cross matching, you see what we are doing, we are matching the patient's cell with the donor's serum, right? Or we are matching the uh, recipient cell with the donor serum, and that is called as the minor cross matching. So when we do this cross matching, we will see any kind of agglutination taking place when we do the cross matching. And if there is agglutination, then we should stop the blood transfusion. But if there is no agglutination, then we can go for transfusion. So these two tests we have to do before the pre-transfusion or before the transfusion. Okay, so we have to do the blood typing and we have to do the cross matching of the blood sample by doing the major cross matching and the minor cross matching. In major cross matching, we are matching the patient's serum with the donor cells, and in minor cross matching, we are matching the patient's cells or the recipient cell with the donor's serum. Now, types of transfusion. So till now we have seen what are the indications for blood transfusion. we have seen which all blood group is universal donor and which all blood group is universal recipient, which blood can receive which blood. So we saw that, and we also saw that how blood has been stored in the blood bank, right? Now we're going to see what are the type of transfusion we can do. So types of transfusion can be based on time of transfusion. So there can be fresh whole blood transfusion. That means we are just transfusing the blood directly we get from the donor, and we are directly infusing in the patient. Or it can be stored citrate phosphate dextrose blood, that is the stored blood by mixing with the citrate phosphate dextrose, right? So that stored blood can also be transfused. So based on the time of transfusion, we have the fresh blood transfusion, or we have the stored blood transfusion, right? Then based on the composition of the blood, there can be whole blood transfusion or there can be fraction of blood transfusion. Then based on the donor, we have the autologous blood transfusion, that is we are transfusing blood to ourselves, right? So we collect the blood beforehand, and whenever we are in need, then same blood of our body can be utilized. That is called as the autologous blood transfusion. Or else we have blood from different donor, right? So these are the different type of blood transfusion we can do. Now let us see the blood component. So we have the whole blood over here, right? And we do slow centrifugation. Now that is, we are gonna put it in the centrifugal machine where there is a rotation of that particular machine, and when it does so, there will be settlement of some of the blood component, and some of them will be above it, right? So the settled sediment is called as the packed red blood cells, and the above one, which is clear, is called as the platelet rich plasma. So the settled component is the packed red blood cells, and the above clear one is the plasma. Now this platelet rich plasma, when we again do high speed centrifugation, then we get the fresh frozen plasma, right? Now this fresh frozen plasma, again we will thaw it, and it will precipitate the plasma protein. Thawing means we are like warming up the blood to some extent, right? So thawing means we are a little bit warming up the this fresh frozen plasma. At that time, when we are warming it, then the concentration of this uh, the constituent will become concentrated, like the uh, clotting factors, they will be concentrated, and that is called as the cryoprecipitate. Okay, so these are the blood components and how we gonna transfuse it depending upon the scenario needed. Okay, so once again, let us see this one. Whole blood, we are slowly centrifugation it, we are slowly doing centrifugation, and when we do slow centrifugation, we get the sedimented packed red blood cells, and then we will get the platelet rich plasma on the top. And this platelet rich plasma, when we do again high speed centrifugation, then we see that again there will be formation of fresh frozen plasma. Now this fresh frozen plasma, when we thaw it, then there will be precipitation of the plasma proteins, leading to concentration of the these coagulation factors, and that is called as the cryoprecipitate. Now depending upon the different scenarios, then we're gonna infuse it to the patient. Now you can see whole blood. When do you use? When there is massive blood loss, when there is trauma, or when there is exchange transfusion needed. At this time we are using the whole blood. Okay, so the whole blood is the blood as such. We take out from the donor. This whole blood, it is indicated at the time of massive blood loss. And then RBC concentrate. After we do the slow centrifugation, then we had this precipitate RBC, right? This packed cell RBC. So this RBC, this RBC concentrated, we are utilizing it, or we are infusing it at the time of anemia, at the time of hypoxia, etc. Now platelet, when we do high centrifugation, then we get this platelet, right? So this platelet, we are infusing it at the time of thrombocytopenia, when there is excessive bleeding, or in case of invasive procedure, we use the platelet infusion. Then this fresh frozen plasma, we are infusing it when there is coagulation factor deficiency. Likewise, cryoprecipitate, we are infusing it at the time of fibrinogen deficiency or dysfibrogenemia, or in case of bone Willebrand disease. In all these cases, we are infusing cryoprecipitate. So depending upon the different scenario of the patient, we have to infuse the blood. It is not that every time we are infusing the whole blood. So depending upon the condition or depending upon the disease the patient is suffering, we have to infuse the blood. It can be whole blood, it can be RBC concentrated, it can be platelet concentrated, it can be plasma concentrated or fresh frozen plasma, and it can be cryoprecipitated. So depending upon the different scenario, we have to infuse the blood to the patient. Now, the main thing is transfusion reaction. So what do you mean by transfusion reaction? You know, when we have done the blood typing, and when we have done this major cross matching and minor cross matching, so if we have done all these procedure properly, then there is these chances there will be some kind of transfusion reaction. But still, even though we are very careful about it, sometimes there can be some kind of reactions occurring during the blood transfusion. And those kind of reactions occurring at the time of transfusion is called as the transfusion reaction. And the cause for transfusion reaction can be many. Like the first one you can see over here, because of the incompatible blood transfusion. It is a very important reaction which we will see if we transfuse the incompatible blood or the mismatched blood to the recipient. Then there can be some kind of chemical risk, there can be allergic reaction, and there can be transmission of diseases when we are transfusing blood. So it is a very important that we rule out various transmitted diseases when we are transmitting the blood or when we are transfusing the blood. So it is very important to find out if there is if the recipient is having any kind of transmitted diseases or not, right? So we will see one by one what kind of reaction can occur during the time of transfusion. So the first one is effect of incompatible blood transfusion. So when we infuse mismatched blood, so you can see over here, this is a donor and this is a receiver. So donor have A antigen because he or she is the blood group A, and he is having antigen A on his RBC membrane, and he has anti-B antibodies in the plasma. Likewise, receiver, he has antigen B on the cell membrane and he has anti-A antibody on its plasma. Now, suppose there was some confusion or because of some laboratory mistake. Now, what happened? We are infusing the type A blood to type B blood group. Then what will happen? So, we are infusing the type A blood group to type B blood group. So, at this time, what can happen? Right? So, we are transfusing one type of donor blood to a recipient who has another blood type, right? So because of that, there will be transfusion reaction to occur where the red blood cell of the donor blood will get agglutinated. So we are infusing the type A blood group to type B. So we have the type A antigen on the surface of the membrane, right, of surface of the RBC membrane, and we have anti-A antibody on the blood group B of the receiver. So when we infused the type A, or when we infuse blood group A to the blood group B, then there will be reaction between the antigen and antibody of this donor antigen and the recipient antibody, which will cause the red blood cell of the donor to get agglutinated, right? Now, it is very rare that the transfused blood will cause agglutination of the recipient cell. So when we are uh, infusing the blood type A to type B, then what is happening? The donor blood cell is getting agglutinated, but it is rare that the transfused blood will cause agglutination of the recipient cells. Why? Because the plasma portion of the donor immediately becomes diluted by the plasma of the recipient over here, right? So thereby decreasing the titer of the infused antibodies to a level usually to cause agglutination, right? So generally when we infuse blood, it is the donor blood which get agglutinated, but not the recipient blood. It is not so because the donor blood, they generally get, because the plasma portion of donor blood, they become diluted by all the plasma of the recipient, and therefore the recipient blood is unlikely to get agglutinated. So that is inapparent hemolysis of the donor RBC generally occur because of the incompatible blood transfusion or because of the mismatched blood transfusion. Now there can be post-transfusion jaundice. I think this is very understood that whenever there is RBC hemolyzed, we know that hemoglobin will be released, right? And this hemoglobin will be converted to the bilirubin, and this bilirubin will be excreted in bile by the liver. Now the concentration of the bilirubin will rise up so much that it will cause the yellowish discoloration of the body, and that is called as jaundice, right? So there is chances of having post-transfusion jaundice. Now, why this post-transfusion jaundice occurs? Because RBC, there is an interaction between the RBC of the RBC of the donor with the antibody of the recipient, and there is antigen-antibody reaction occurring. Because of that, there will be RBC hemolysis, and because of that, hemoglobin will be released, and hemoglobin will be converted to bilirubin. And as there is increased amount of bilirubin in the body fluid, it will cause jaundice. So that is called as the post-transfusion jaundice. Now, the very important feature, a very important thing is there can be acute kidney shutdown after transfusion reaction. Okay, so the kidney failure can occur, acute kidney failure can occur after transfusion reaction occur. Now why this transfusion reaction, or why this kidney shutdown occurs? Now as I told you, because of the mismatched blood, there can be antibody reacting with the antigens, right? So when there is antigen antibody reaction, or when the antibody bind to the antigen, then what happens? You have already seen in the immunity, right? Whenever antibody binds to antigen, there can be complement fixation, right? And there can be release of anaphylatoxins, and these anaphylatoxins are the chemicals which are going to cause now this histamine can cause bronchoconstriction, which can cause smooth muscle contraction, and there can be hypotension. At the same time, they can cause increase permeability of the blood vessels, so blood flow into the tissues will be more, and because of that there will be decrease in the arterial blood pressure, leading to hypotension, and eventually there can be shock, right? Now as you see that there is increased permeability of the blood vessel is getting increased, so the amount of blood that is reaching the kidney will also be decreased, right? Now as the blood which is reaching the kidney is decreased, that means there will be decrease in renal blood flow, leading to decrease in urine output as well, right? So we are seeing what happens after the transfusion reactions. So whenever there is mismatched blood transfusion, there can be reaction between the antibody and antigen, which will lead to complement fixation. Now this complement fixation will cause, or it will stimulate the anaphylatoxins. Anaphylatoxins are the chemicals that will cause degranulation of the mast cell, releasing histamine. Now this histamine will cause increased permeability of the blood vessels, and it will cause increased blood flow into the tissues. So when there is increased blood flow into the tissues, the blood going to the renal area is also decreased, which will lead to a decrease in urine output. And at the same time, there will be decrease in the arterial blood pressure, leading to shock, right? Now, that is first portion, why shock can occur because of the transfusion reaction. And you saw that because of transfusion reaction, there is decrease in renal blood flow, leading to decrease in urine output. At the same time, we can see that hemoglobin is been continuously being released because of this interaction between the because of this agglutination reaction occurring because of the antigen and antibody reaction. Now, when there is a breakdown of the RBC, so there will be free hemoglobin released into the circulating blood, right? Now, if and this free hemoglobin, they are going to bind with the haptoglobin. So we have a protein called as haptoglobin, which will bind the free hemoglobin generally, right? But if the if the hemoglobin release is very high, then haptoglobin will not be sufficient to bind with the hemoglobin, right? And this hemoglobin will go to the kidney tubules. Now, these in the kidney tubules, what happens? There will be continuous reabsorption of the water taking place, and it will cause the tubular hemoglobin to rise so high that the hemoglobin will precipitate and block the tubules. That will again lead to anuria, or there is no urine formation. So that is also a part of acute renal failure. So you see there is continuous breakdown of RBC leading to free hemoglobin in the circulation. Now this free hemoglobin, they are they are going to bind with the haptoglobin. But if the free hemoglobin produced is so much, then this free hemoglobin is going all the way to the kidney tubules. In the kidney tubules, then the water is going to get reabsorbed, but this hemoglobin will be precipitate in the kidney tubules. And when they precipitate in the kidney tubules, what happens? They will be blocking the kidney tubules, and that will lead to renal failure, and that will lead to decrease, or that will lead to no urine formation, and the condition is called as anuria. Likewise, still, if we do not treat the patient again, then there will be renal failure, right? And there will be increased nitrogenous substance and potassium in the body, like because the kidney is not working right now, and because of that there will be increased nitrogenous substance and potassium in the body, which is called as uremia, and the person will have lethargy, coma, and finally death. So acute kidney shutdown is one of the very dangerous condition which can occur because of the inappropriate blood transfusion. And generally, after infusing blood, the first thing the patient will complain of is violent pain in the back or elsewhere, and tightness in the chest because agglutinated RBC form clump which block the capillaries. So, right after blood transfusion, the first complaint which the patient will say is they have a very violent pain in the back generally, or it can be somewhere else, and they will feel the tightness in the chest because this agglutinated RBC they will form clump which will block capillaries, right? So this is the acute kidney failure or acute kidney shutdown. So it can occur because of shock, first of all, right? Because of this increased histamine release, which is causing decrease in blood flow to the kidney, leading to decreased urine output, first thing. Secondly, there will be uh, increased hemoglobin precipitate in the kidney tubules, which will block the kidney tubules, and there will be precipitation of the hemoglobin, and which will cause the blockage of the kidney tubules, and there will be anuria. And lastly, there will be increased nitrogenous substances in the body, which will cause uremia in the body, and the person will finally die of lethargy, coma, and finally there will be death. Now, some of the chemical risk because of the blood transfusion is stored blood cells. One of the drawbacks mature blood cell is that they will lose potassium to the external plasma. It will lead to hyperkalemia in the body, and hyperkalemia is also a very dangerous condition which will lead to all kind of uh, signs and symptoms in the body. Now, with massive transfusion of the citrated blood, normal conversion of citrate to bicarbonate by the tissue may be delayed. Right? We are transfusing a blood which is combined with the citrate, dextrose, adenine. Right? So, and if we are transfusing a very massive blood transfusion, we are doing it. Then what will happen? The conversion of the citrate to bicarbonate will be delayed, and as a result, patient may suffer from lack of ionized calcium, because citrate, it is a calcium chelating agent, and as citrate is been uh, decreased, it will cause the decrease in calcium level in the body, and that will lead to tetany. So what is tetany? Tetany is basically a condition which occurs because of decreased calcium level in the body, and whenever there is decreased calcium level in the body, we will have all kind of spasm in our body, and all kind of this spasm all over our body. It is called the tetany, which we will study in the endocrine system. Now there can be allergic reaction, like there can be rash, there can be anaphylactic shock, there can be urticaria. It is like some people, they are just allergic to. Um, in fact, even those everything has been matched, but still some people, they tend to show allergic reaction, right? And there can be transmission of diseases like malaria, syphilis, and AIDS. So we have to rule out, we have to check the blood properly before getting transfused into the patient. Okay, thank you. So this was transfusion and the transfusion hazards. So from today's class, the thing which you have to know is what are the indication of blood transfusion. Then you have to know what is universal recipient and a universal donor. Then we have to know how this blood is being stored, in what chemicals they are being stored, right? And the very, very important topic, or very important from the exam point of view, is you have to know the transfusion reactions. Okay, you'll be asked as write about transfusion reaction, or you'll be asked about write about hazards of blood transfusion. In both cases, you have to write the same answer. All of these points have to come under transfusion reaction. All right. So that was for today's class, and if you have any doubt, you can just text me. All right.